In this lesson, we will learn hospital inpatient and observation EM services based on the latest CPT guidelines. You will understand the differences between observation care and inpatient care, initial and subsequent hospital visits, discharge day management, newborn inpatient services, coding guidelines, and how to correctly select EM codes using medical decision-making or total physician time. These concepts are frequently tested in the CPC examination and are also essential in real-world medical coding. Let's begin today's lesson. Before we begin, this training is for educational purposes only. Always refer to the latest CPT, ICD-10CM, HCPCS Level 2 manuals, payer policies, and official coding guidelines when assigning medical codes. In this lesson, we're going to learn about inpatient and observation EM services. We'll understand what observation services are, what inpatient services are, and the differences between them. We'll also discuss initial hospital care, subsequent hospital care, hospital discharge services, and the CPT coding guidelines used for these services. By the end of this lesson, you'll know how to select the correct EM level using medical decision-making or total time, and you'll be better prepared for the CPC exam. So, let's get started. Let's begin with hospital observation services. Observation care is a short-term hospital service used when a physician needs additional time to evaluate, monitor, or treat a patient before deciding whether the patient should be admitted as an inpatient or safely discharged. During observation, the patient's condition is closely monitored, and the physician determines the most appropriate plan of care. Hospital inpatient services are provided after the physician formally admits the patient to the hospital. Inpatient care is intended for patients who require continuous medical treatment, monitoring, or procedures that cannot be safely managed in an outpatient or observation setting. Most inpatient admissions involve at least one overnight stay, although the admission decision is based on medical necessity rather than simply the length of stay. A hospitalist is a physician who specializes in caring for hospitalized patients. The hospitalist evaluates the patient, orders observation or inpatient services when appropriate, manages treatment during the hospital stay, and coordinates care with specialists and other healthcare professionals until the patient is discharged. Hospital EM services follow a logical sequence. Some patients are admitted and discharged on the same day. Others receive initial hospital care on the first day of admission, followed by subsequent hospital care on later days as their condition is monitored and treated. Finally, when the patient is ready to leave the hospital, the physician performs hospital discharge management. The key difference between observation and inpatient services is the patient's status. Observation care is temporary and helps the physician determine whether hospital admission is necessary. Inpatient care begins after a formal admission order and is intended for patients who require more intensive treatment and monitoring. As a medical coder, always verify the patient's admission status before selecting the appropriate EM code. Let's begin with initial hospital care. Initial hospital care is reported for the physician's first encounter with a patient after hospital admission. The patient must not have received any previous professional services during the same hospital stay from the same physician or another qualified healthcare professional of the same specialty and group practice. This service represents the physician's first comprehensive evaluation and management of the hospitalized patient and is reported only once during that admission. Subsequent hospital care is reported for follow-up visits after the initial hospital care has been provided. During these encounters, the physician evaluates the patient's progress, reviews test results, adjusts treatment plans, and monitors the patient's response to therapy. Since the patient has already received professional services during the same hospital stay, these visits are coded as subsequent hospital care. These services may be reported on each medically necessary hospital day until the patient is discharged. Hospital Discharge Day Management is reported on the day the patient leaves the hospital. Before discharge, the physician performs a final evaluation to ensure the patient is medically stable. The physician reviews the patient's progress during hospitalization, confirms that treatment goals have been achieved, and determines whether the patient can safely continue care outside the hospital. This service represents the physician's professional work completed on the final day of hospitalization. Discharge day management includes several important physician responsibilities. The physician prepares the discharge summary, completes prescriptions, and provides referral forms if additional care is needed. The patient and caregivers receive clear instructions regarding medications, diet, activity restrictions, follow-up appointments, and warning signs that require immediate medical attention. Proper documentation of these discharge activities is essential because all physician work performed on the discharge date is included in the discharge management service. Inpatient newborn care services apply to newborn infants from birth through the first 28 days of life. CPT provides different E/M code categories depending on the condition of the newborn and the level of physician services provided. Healthy newborns, newborns requiring stabilization, NICU patients, and critically ill infants all have different code sets. Understanding these categories helps coders report newborn hospital services accurately. Some newborns require physician attendance during delivery because of anticipated complications. After birth, the physician may provide routine stabilization or advanced resuscitation. Initial stabilization includes immediate assessment and management of the newborn. Delivery room resuscitation involves more intensive life-saving interventions such as assisted ventilation or chest compressions. CPT assigns separate codes based on the level of care provided. A healthy newborn admitted to the hospital receives normal newborn care. The physician reports initial hospital care on the first day and subsequent hospital care on following days. If the newborn is admitted somewhere other than the birthing hospital, a different captain code is used. When admission and discharge occur on the same date, captain provides a separate same-day admission and discharge code. Neonatal intensive care services are reported for newborns requiring specialized intensive treatment. Initial NICU care is reported using CPT 99477. Subsequent daily NICU care is selected according to the infant's present body weight. Accurate documentation of the baby's current weight is essential because it directly determines the appropriate captain code. Some newborns require critical care because of life-threatening conditions. These infants need constant physician attention and advanced medical support. CPT provides one code for the initial day of critical care and another for each subsequent day. Critical care coding depends on the severity of illness rather than routine newborn management. For the CPC exam, remember that newborn E/M coding covers only the first 28 days of life. Always determine whether the infant is healthy, requires intensive care, or is critically ill. For NICU services, pay close attention to the infant's documented present body weight because it determines the correct subsequent care code. Reading the physician's documentation carefully is the key to accurate newborn coding. The correct answer is CPT 99477. This code is reported for initial hospital care of a neonate requiring intensive care. Code 99460 is for a normal newborn's initial hospital care, 99462 is for subsequent normal newborn care, and 99468 is used for newborn critical care, which involves a higher level of illness than routine neonatal intensive care. In addition to understanding hospital inpatient and observation E/M codes, coders must also follow the captain reporting guidelines. These guidelines explain how physician time is calculated, how services crossing midnight are reported, and when modifier AI should be assigned. Understanding these rules helps ensure accurate code selection and proper reimbursement. When reporting hospital inpatient or observation discharge day management, physicians report the total amount of time spent caring for the patient on the discharge date. The time does not have to be continuous. Multiple patient encounters throughout the same day are added together to calculate the total physician time. This cumulative time is used when selecting the appropriate discharge management service. CPT instructs physicians to calculate total physician time based on the calendar date. Even if several patient encounters occur during the same day, all physician work performed on that date is combined. Coders should always verify the documented service date before selecting the appropriate E/M code. Sometimes physician services continue across midnight. CPT states that when medical decision-making or total time is used for code selection, a continuous service that extends into the next calendar day is reported as one single service. The physician should not split the encounter into two separate services simply because the clock passes midnight. Modifier AI stands for Principal Physician of Record. This modifier is appended to the initial hospital visit submitted by the admitting physician. Its purpose is to identify the physician who has overall responsibility for managing the patient's hospital care. Other physicians, such as consultants or specialists, do not report modifier AI because they are providing specialty services rather than directing the patient's overall care. For the CPC exam, remember that modifier AI belongs only on the admitting physician's initial hospital service. In some situations, a patient is admitted to the hospital or placed under observation, receives physician care, and is discharged on the very same calendar day. CPT provides a separate group of EM codes for these encounters. Instead of reporting separate admission and discharge services, a single admission and discharge code is selected. The physician should document either the medical decision-making level or the total physician time, depending on captain guidelines. When selecting a same-day admission and discharge code using medical decision-making, captain recognizes 4 MDM levels. Straightforward and low MDM are reported with CPT 99234. Moderate MDM is reported with CPT 99235, while high MDM is reported with CPT 99236. Accurate documentation of the patient's problems, data reviewed, and risk is essential because these 3 elements determine the final MDM level. CPT also allows physicians to select these codes using total physician time. If total time is between 45 and 69 minutes, report CPT 99234. A total time of 70 to 84 minutes is reported with CPT 99235. When physician time reaches 85 minutes or more, CPT 99236 is reported, and prolonged service codes may also apply depending on payer rules. For Medicare patients, prolonged physician services are reported using HCPCS code G0316 after CPT 99236 when the physician spends significantly more time than the base service. Additional G0316 units are added as total physician time increases according to Medicare guidelines. Always verify the current Medicare rules before reporting prolonged services. For commercial insurance and other non-Medicare payers, prolonged physician services are generally reported using captain add-on code 99418. Once physician time exceeds the base service time for CPT 99236, additional 99,418 units may be reported according to captain time thresholds. Coders should always confirm each payer's policy because prolonged service reporting can differ between Medicare and commercial insurers. For the CPC exam, remember that when admission and discharge occur on the same calendar day, only one EM code is reported. Code selection may be based on either medical decision-making or total physician time, depending on the documentation. Also remember the prolonged service add-on codes. G0316 is used for Medicare, while CPT 99418 is generally used for non-Medicare payers. Understanding these distinctions will help you answer EM coding questions accurately. Subsequent hospital care is reported for physician services provided after the patient's initial admission. These visits usually occur on the second day of hospitalization and continue until discharge. During these encounters, the physician evaluates the patient's progress, reviews test results, adjusts the treatment plan, and documents the appropriate medical decision-making or total physician time. CPT allows code selection using either MDM or total time, depending on the documentation. When coding subsequent hospital care using medical decision-making, captain recognizes 4 MDM levels. Straightforward and low MDM are reported with CPT 99231. Moderate MDM is reported with CPT 99232, while high MDM is reported with CPT 99233. The physician's documentation of the patient's problems, data reviewed, and risk determines the correct MDM level. CPT also allows physicians to select subsequent hospital care codes using total physician time. If the physician spends between 25 and 34 minutes, CPT 99231 is reported. A total time of 35 to 49 minutes corresponds to CPT 99232. When physician time reaches 50 minutes or more, CPT 99233 is reported. Accurate documentation of total physician time is essential when using the time-based method. For Medicare beneficiaries, prolonged physician services after CPT 99,233 are reported using HCPCS add-on code G0316. When the physician spends additional qualifying time beyond the base service, one or more units of G0316 may be reported according to Medicare guidelines. Always review current Medicare rules before assigning prolonged service codes. For commercial insurance and other non-Medicare payers, prolonged physician services are generally reported using Captain add-on code 99418. After the physician exceeds the base service time for CPT 99,233, additional units of 99,418 may be reported according to Captain guidelines. Always verify payer-specific requirements because some insurers follow different prolonged service policies. For the CPC exam, remember that subsequent hospital care codes are used after the patient's initial hospital encounter. Code selection is based on either medical decision-making or total physician time. Know that CPT 99,231 represents straightforward or low MDM, CPT 99,232 represents moderate MDM, and CPT 99,233 represents high MDM. Also remember the prolonged service add-on codes. G0316 is used for Medicare, while CPT 99,418 is generally used for non-Medicare payers. These coding rules are frequently tested on CPC certification exams. Hospital inpatient or observation discharge day management is reported on the day the patient leaves the hospital. CPT provides two codes based on the total physician or qualified healthcare professional time spent on the discharge date. Captain 99,238 is reported when the total time is 30 minutes or less. Captain 99,239 is reported when the total physician time exceeds 30 minutes. The physician should accurately document the total discharge time to support the selected code. Discharge day management includes much more than simply releasing the patient from the hospital. The physician performs a final examination, reviews the patient's hospital course, prepares the discharge summary, writes prescriptions, completes referral forms if needed, and provides instructions regarding medications, activity, diet, and follow-up appointments. All physician services performed on the discharge date are included when calculating the total discharge management time. For the CPC exam, remember that discharge day management codes are reported only when the patient is discharged on a date different from the admission date. If admission and discharge occur on the same calendar day, you should report the same day admission and discharge EM codes instead. Always review the physician's documentation to verify the discharge date and the total physician time. Proper documentation supports accurate code selection and appropriate reimbursement. Let's apply what we've learned with a real coding scenario. A patient is admitted to the hospital because of suspected gallstones. On the admission day, the physician performs the initial hospital evaluation and orders diagnostic testing. The following day, the physician reassesses the patient, reviews the test results, performs a medically appropriate history and examination, and documents low-complexity medical decision-making. Since this is not the admission day but a later hospital visit, we need to identify the correct subsequent hospital care code based on the documented MDM level. Think carefully before looking at the answer. The correct answer is Captain code 99231. Here's the reasoning. The patient was admitted on the previous day, so today's visit is considered a subsequent hospital care service rather than an initial hospital care service. The physician documented medically appropriate history, medically appropriate examination, and low-complexity medical decision-making. No total physician time was documented, so code selection is based on the MDM level. Low-complexity MDM corresponds to Captain code 99231 for subsequent hospital care. Remember this important CPC exam rule. Initial hospital care codes are reported only once on the admission date, while all later inpatient visits are reported using subsequent hospital care codes. Always determine whether the service occurred on the admission day or a later day, and then select the code using either MDM or total physician time, depending on the documentation. Let's practice another CPC-style coding question. A patient arrives with severe nausea and vomiting and is placed under hospital observation after the physician performs a medically appropriate history and examination. Moderate medical decision-making is documented on the admission day. The patient remains in observation overnight and is discharged the following day. On the discharge day, the physician spends 25 minutes completing the discharge management activities. Your task is to determine the correct Captain EM code for the discharge service. Remember that discharge day services are coded separately from the initial observation admission. The correct answer is Captain code 99238. Here's why. The patient was admitted to observation on one day and discharged on the following calendar day. Because the discharge occurred on a different date, we report a hospital observation or inpatient discharge day management code rather than an admission code. CPT provides two discharge management codes. Code 99238 is used when the physician spends 30 minutes or less performing discharge activities. These activities include reviewing the patient's hospital course, completing discharge documentation, writing prescriptions, providing discharge instructions, coordinating follow-up care, and communicating with the patient or caregivers. Code 99239 is reported only when the physician spends more than 30 minutes on discharge management. In this case, the physician documented 25 minutes, so the correct code is 99238. For the CPC exam, always remember that discharge management codes are selected according to the documented discharge time, not the medical decision-making level. Congratulations on completing Lesson 6. In this lesson, we covered hospital inpatient and observation evaluation and management services. We learned the difference between observation and inpatient care, initial and subsequent hospital visits, discharge day management, newborn inpatient services, and important Captain coding guidelines. We also practiced coding scenarios similar to those seen on the CPC exam. A clear understanding of these concepts will help you accurately assign EM codes in both examinations and real-world medical coding. In our next lesson, we will begin emergency department evaluation and management services. Thank you for learning with KS Medical Coding Academy. Thank you for watching this lesson from KS Medical Coding Academy. I hope this session helped you understand hospital inpatient and observation EM services more clearly. If you found this lesson useful, please like the video, share it with other CPC aspirants, and subscribe to the channel for more medical coding lessons. Don't forget to turn on notifications so you never miss an upcoming class. I'll see you in the next lesson on emergency department EM services. Thank you, and happy learning.